Barbour. Dr. Barbour completed his pediatric residency at Norton Children's Hospital in the University of Louisville before going on to a pediatric HEMONC fellowship at Penn State Hershey Children's Hospital. We were excited to have him return last year to join us at Norton Children's Hospital again as an associate professor in the Division of Hematology Oncology. And he is currently the co-director of the Neuro-Oncology program at Norton Children's Hospital and serves as the Pediatric Fellowship Director. So please welcome Dr. Barbour. He's going to talk about recognizing and diagnosing childhood cancers.
Thank you. Good morning, everybody. It's my pleasure to be here. I see a lot of familiar faces. It feels great to be back in Louisville. I will be talking to you today about diagnosing childhood cancer. Do I need to do anything from my end to get the slides? All right, so I have no conflict of interest. My goal today is to talk to you guys about epidemiology of childhood cancers and quickly go over clinical presentation of common childhood malignancies and then review some of the oncologic emergencies we see. Overall, cancer is luckily very rare. In kids, we see around 12,000 cases every year. Depending on the age group, some of these malignancies are common, others are rare. Overall, regardless of the age group, leukemia and CNS tumors, brain tumors are the most common malignancies we see. And then depending on the age group, there are things like neuroblastoma, which we commonly see in the younger age group, and things like bone and soft tissue tumors and lymphomas, which we see in the older age group. The bad news is that childhood cancer has been slowly but steadily increasing over the past 35 to 40 years. The good news is that mortality has been steadily decreasing. So my goal today is to talk about the most common types of cancer, not all of them. And I will start with acute leukemia, essentially cancer of the bone marrow. And depending on the cell of origin, some of the leukemias are myeloid and others are lymphoid. When you compare incidence of ALL and AML, clearly ALL is much more common. And one thing unique about ALL incidence is that it has a really sharp peak at around age 2 to 4. That's the most common age group that we see. So a classic presentation for a child with acute leukemia. This is a real story. So a 2-year-old boy, he presented with the following story. So his mother reported that he was feeling just fine until 6 to 8 weeks ago when he started to feel just kind of tired, he's fussy. She feels that he has been achy all over, and his grandmother kept telling his mom that he looks pale. Then he develops fever for a few days, and he presents with bruises and rash, and he comes to see his primary doctor. So common findings on exams, these kids typically come with fever, tachycardia, tachypnea, they have pain, they have pallor, bruises, and petechial rash. Depending on the type of leukemia, they may have hepatosplenomegaly and enlarged lymph nodes, and sometimes they have palpable subcutaneous nodules or chloromas, and that's usually the case in AML and infant ALL, much more common in AML. Usually they have leukopenia or leukocytosis, they have normocytic anemia, thrombocytopenia, and when you look at the diff, they are typically neutropenic, and they commonly have circulating blasts. So when we hear about child with possible leukemia, the first question that comes to mind is that does the child have any emergency? And the common emergencies we see are sepsis, tumor lysis syndrome. We worry about the airway in case the child has a mediastinal mass, leukostasis, and an AML. Sometimes they present with DIC. And then the second question, is it really leukemia? So answering the second question is relatively easy. Usually we do bone marrow aspiration, and depending on what we find, we can, the same day, we can tell if a child has acute leukemia or not. So on the left side of the screen, you see a normal-looking bone marrow, different cells, different shapes, different sizes. On the right side of the screen, you see a bone marrow that's replaced with these small round blue cells, essentially acute leukemia cells. And then we do flow cytometry typically to determine is it AML or is it ALL. And if it is ALL, we stratify these kids into different groups so we can treat them. Most of what we see are the precursor B, which are relatively easier to treat, followed by T-ALL, and then there are special groups that we treat a little bit differently, like infants, kids with Down syndrome, and kids who have Philadelphia chromosome. This is a common slide that I'm sure most of you have seen. Our success story was treating ALL. And it's not only a success story of science, it's also a success story of collaborative efforts. So starting back in the 40s, we really did not know how to treat any of the leukemia patients. And then by the 70s, the cure rate improved, and it was around 50%. And now it's a little bit above 90%, including all patients. AML, let's say it's a little bit more simple in a way, depending on their molecular changes and their response to treatment. We divide them into low-risk AML and high-risk AML. The low-risk group usually get chemotherapy alone. The high-risk group typically, once we get them to remission, we take them to bone marrow transplant. Then moving on to talk about leukemia, we see both Hodgkin's and non-Hodgkin's leukemia in kids. Lymphoma becomes the most common malignancy in the teenage years. So after age 13 or 14, we see significant increase in incidence of lymphoma, both Hodgkin's and non-Hodgkin's. During the first 10 years of life, it's most likely to be non-Hodgkin's. In teens, it's usually Hodgkin's much more commonly than non-Hodgkin's. So when you think lymphoma, I'm sure that you guys are thinking enlarged lymph nodes. And enlarged lymph nodes in malignancy, you can see them in different diagnoses. Lymphoma, leukemia, histiocytosis can present with enlarged lymph nodes, and of course metastatic disease to the lymph nodes. For the purpose of this talk, I'm going to focus on lymphoma and enlarged lymph nodes. So when you see a child with lymphadenopathy, and the question is it cancer or not? Most of what we see, probably the kids who have just reactive lymph nodes, and that's relatively easy to reassure the family and arrange for follow-up or not follow-up. Those are usually the kids who have a clear source to have reactive lymph nodes. Much less commonly, you see the concerning type of lymph nodes, and these are the kids who present with, really significant enlargement in their lymph nodes. They have other systemic symptoms, and those are the kids who typically have lymph nodes for a while. It hasn't gone away, and they have, again, systemic symptoms. And for these kids, these should be evaluated for emergencies and then referred to oncology. And a good number of the kids you see, they are in between, so you're not sure why they have enlarged lymph nodes, but at the same time, they look well and they do not have any concerning symptoms. So for those kids, I would advise that we rule out emergencies and then follow up with or without antibiotics, and I would definitely not recommend using steroids for these kids. So examinations, the key things would be just trying to characterize the lymph nodes where they are, just any systemic symptoms accompanied with them, and again, trying to see if there's a kind of lymph nodes that would make you concerned or not. So characteristics that would increase the chances of a child with enlarged lymph nodes having malignancy are increasing age. So again, teenagers are more likely to have lymph nodes that are malignant compared to the younger age group. If the size of the lymph nodes is significant, more than 2 centimeters, increasing number of sites of lymphadenopathy, certain sites like supraclavicular lymph nodes, of course fixed lymph nodes, associated systemic symptoms like night sweats and weight loss. If somebody has widened mediastinum on the chest X-rays, that's typically concerning, and also if you can't explain it by any infectious symptoms. The classic B symptoms are fever with no clear infection, drenching night sweats, and significant weight loss. That's typically defined as weight loss more than 10% over the 6 months prior to diagnosis. Less important and less common systemic symptoms that comes with lymphoma are pruritic rash, fatigue, and decreased appetite. Some of the emergency presentations with lymphomas, again, commonly we see mediastinal mass, so we worry about airway compression in these kids. Certain non-Hodgkins, they can present with pleural effusions or pericardial effusion. They can present with superior vena cava syndrome. Again, if it's really close to the spine, invading the spinal canal, they can present with back pain or paralysis. Tumor lysis, of course, can happen, especially in Burkitt's and lymphoplastic lymphomas. Kidneys can be affected, again, commonly in Burkitt's because it tends to be abdominal and it can cause ureter compression or indirectly by increasing uric acid. Burkitt's can present with bowel obstruction, intussusception. That's relatively common presentation. And if it's a lymphoma that's involving the bone marrow in a significant way, those kids usually have cytopenias. It's very sensitive. All right, so workup to rule out emergency, again, for that gray zone group of kids, the ones who have somewhat concerning lymph nodes, but they are doing okay otherwise. I would suggest the following workups. You do CBC with differential CMP, phosphorus, uric acid, LDH, and chest X-ray to make sure their mediastinum is not widened and that they don't have perihilar lymph nodes. Moving on to talk about brain tumors. This is a picture of a baby who I treated in the past, and you see this huge brain tumor, and in this case was 4-month-old baby. One thing unique about babies is that the tumors can get really huge before they become really symptomatic because of the open sutures, and they just tolerate everything a little bit better. So when I moved back to Kentucky, one thing that I was told is that we see a lot of brain tumors, and it is true. If you look at the most common 10 malignancies in the United States, you see that CNS tumors are more common in Kentucky, which is represented in orange, compared to the entire country, the average for the USA. And here in Louisville, some years we see more brain tumors than leukemias. And the same is true for retinoblastomas. So I chose to talk about both today. So around 25% of all cancers that we see are brain tumors or spine tumors. The overall 5-year survival is decent, is around 75%, but unfortunately most of these kids, they end up with long-term sequelae. And it is now, with improvement in leukemia treatments, brain cancer is now the most, or the leading cause of cancer death in the United States. There are too many different brain tumors that we see. Unfortunately, I don't have the time to go over them one by one. I would love to try that. But around 50% of these tumors are benign, meaning that under the microscope, they are low grade. But this young man here has a low grade or benign tumor in a really bad location. And those kids are really treated with chemotherapy for a long time, and because their tumors are not resectable. So for all acute purposes, we treat them like they have cancer. Clinical presentation of brain tumors. Some of the clinical symptoms are just generalized, and that's common for infants. They tend to come with just kind of failing to thrive, or just not developing appropriately, or losing some of the developmental milestones. In older kids, typically it is signs of increased intracranial pressure, and those are usually tumors located to the posterior fossa or the dorsum of the midbrain. And there are localizing symptoms depending on the location of the tumor. So when they present with increased intracranial pressure, the common presentation or common symptoms are headache, vomiting, lethargy, irritability, behavioral change, but they also can present with cranial nerve palsies, like the most common one would be cranial nerve number 6, and they can present with vertical gaze palsy. Depending on the location of the tumor, you can have different symptoms or signs. If it's in the cerebellum, usually they present with ataxia plus minus nystagmus. Brainstem, typically they have, in addition to increased intracranial pressure symptoms, they have gait abnormalities and cranial nerve palsies. Optic nerve or optic tract usually affects vision. Cerebral cortex, they commonly present with seizures, headache, or neurologic deficit. In the hypothalamus, which is relatively common location for gliomas in children, they present with DI. It usually compresses the chiasm, so they have vision changes, and they commonly have short stature, or they can present with failure to thrive, which is the diencephalic syndrome. So these are kids who are consuming enough calories, but they are still losing weight. Depending on age, the tumors can be more likely to be supratentorial or infratentorial. So in the babies, usually it's supratentorial. In age 3 to 9, it's usually posterior fossa, and then in the older kids and adults, it's most commonly to be supratentorial. We're lucky in kids because most of what we see are the low-grade gliomas. We rarely, well, not rarely, but much less commonly, we see high-grade gliomas. And also we see embryonal tumors like medulloblastoma. And one advantage to, or if there is anything good about embryonal tumors, is that they are sensitive to chemotherapy. So outcome for kids with CNS tumors is much better compared to adults with brain tumors. Diagnosis usually with imaging, so we do MRI typically, and then we talk to the surgeons about best safe resection. If the surgeons say yes, we can take it all out, that's great. If not, usually we'd get at least a biopsy or debulking. All right, I'm just going to put a few slides about retinoblastoma. Retinoblastoma is luckily rare. It's the most common intraocular cancer in kids. We see around 10 to 14 per million child, usually the younger age group, age 0 to 4. Most of the kids present during the first 2 years of life, and almost all of them present by age 5. 1/3 of the kids has bilateral, and essentially they have inherited retinoblastoma or hereditary retinoblastoma. In places where good access to medical care, usually kids present early on when the retinoblastoma is limited to the eye. And unfortunate, in certain areas with lack of access to medical care, typically they present later, and they are commonly metastatic, not only locally invasive, but metastatic as well. Then I'm going to move on to talk about different tumors, but they share the location. So these are tumors that are usually presenting with abdominal mass, neuroblastoma, nephroblastoma or Wilms tumor, and hepatoblastoma. So neuroblastoma is one of the most common solid tumors we see in childhood, around 650 cases in the entire country every year. Most of the kids we see are young, almost 1/3 are babies, and the majority of them are, they present by age 5. Clinical presentations, the most common clinical presentation is abdominal mass. Infants, they tend to present with respiratory distress because they tend to have massive liver metastases. Older kids commonly present with bone pain and pancytopenia because they have metastatic disease to the bone, and they look really like acute leukemias. They can present with systemic symptoms like fever, hypertension. They sometimes have proptosis and periorbital ecchymosis. They may present with Horner syndrome if neuroblastoma is located to the cervical region. They can have some paraneoplastic neurologic findings like cerebellar ataxia and opsoclonus myoclonus. Babies can present with the blueberry muffin rash. Those are the younger group of kids. Diagnosis usually with tumor imaging. Usually we get tumor catecholamines. It's high in around 95% of the kids. Usually these kids get biopsy, and the outcome vary. Like in this MRI, you see a very aggressive tumor, most likely in an older child, and these kids with really aggressive long treatment, their outcome still okay. It's around 60 to 65% currently. The infants do much better with cure rate around 90% or above. Moving on, Wilms tumor, relatively common. It's most commonly seen during the first 5 years of life. Around 650 cases in the entire United States. One thing unique about Wilms tumor is that a good number of the kids, around 10% of the kids, they have their Wilms tumor is part of a bigger syndrome. These are some of the most common syndromes that predispose kids to having Wilms tumor. Weger syndrome, these kids present with Wilms tumor, aniridia, GU abnormalities, and mental retardation. Vic with Wiedemann is one of the most common overgrowth syndromes, and other congenital overgrowth syndromes can predispose to Wilms tumor, and there are other non-congenital overgrowth syndromes that can predispose to Wilms. These kids we usually see every 3 months or so from day 1 of life, and we screen them with abdominal ultrasounds and because they also tend to have hepatoblastoma, so we usually do alpha-fetoprotein. Most of the kids with Wilms, they present with asymptomatic mass. Usually mom is the one who discovers it during dressing the child or giving him a bath. Abdominal pain is relatively common, around 40% of the kids. Gross hematuria is around 20% of the kids, and these kids can present with hypertension. They rarely have constitutional symptoms. So, neuroblastoma commonly present with some systemic symptoms. It's not likely in Wilms tumor. For diagnosis, we use imaging. Usually these kids go to surgery first. Most of the time it's unilateral. So these kids end up having the tumor resected first, and then we follow that with chemotherapy and radiation. And their survival rate is really decent, around 85 to 90%. Hepatoblastoma is rare. One thing interesting about hepatoblastoma is that it's increasing in the country, and that's at least in part because of increasing survival of the very low birth weight premature infants. And that's a well-known, well-established risk factor for hepatoblastoma. There are conditions associated with hepatoblastomas, like Aicardi syndrome. This is a syndrome where they have seizures, absent corpus callosum, Bequith-Wiedemann, familial adenomatous polyposis, again low birth weight infants, and in some of the glycogen storage diseases. Usually they present with asymptomatic abdominal mass, and if the tumor is really large, they can present with feeding intolerance, anorexia. It gets ruptured. That's rare. Luckily, if it is ruptured, they present with acute abdomen. For diagnosis, we use imaging, MRI or CT scan. Alpha-fetoprotein is a very good marker, and in these kids, usually biopsy, they get chemo and surgery. The overall survival is around 70%. And really depending on how the degree of liver involvement, some of these kids may need liver transplant. I'm going to quickly talk about the most common sarcomas we see in children before I end. So we see Osteosarcoma, Ewing sarcoma, and Rhabdomyosarcoma. Starting with Osteosarcoma, around 5% of what we see. Most of the kids we see are teens. And as you see here, and the red line represents osteosarcoma, so it peaks in late teen and early adulthood. The most common presenting symptom is pain, and most of these tumors arise from the long bones around the knee. Diagnosis, usually we do imaging for diagnosis and for staging. These kids usually get biopsies, they get chemotherapy, surgery to hopefully remove the tumor, and then more chemotherapy. Survival is decent as long as it's not metastatic. The kids with metastatic disease, they do significantly worse. For the kids who do not have metastatic disease, their survival is really good, 76% for the younger age group and 66% for the older kids. Ewing sarcoma is also relatively common in kids. Most of the kids, again, just like osteosarcoma, they present between age 10 and 20, and we see a few cases per year. So still, it's very rare, but it's one of the most common sarcomas we see. And it's represented in the green line in this graph. Clinical presentation, usually these kids present with pain. The pain can be intermittent, and interestingly, it can get better at night. So these kids may say, well, it really hurts, but I'm fine at night, unlike leukemia. Usually these kids have palpable mass, most commonly in the lower extremities, much more commonly than the upper extremities. They can have a mass in the pelvis, chest wall, or different parts of their body. Similar to osteosarcoma, we typically start with imaging. We do biopsy. These kids get 12 weeks of chemotherapy followed by surgery and or radiation, and then more chemotherapy. And their overall survival is decent as long as they are not metastatic. Metastatic disease is very hard to treat. Again, numbers are really similar to osteosarcoma. Rhabdomyosarcoma, we see a few cases every year. It accounts for almost 3% of childhood malignancies. One thing that's different about rhabdomyosarcoma is that it's relatively common during the first 10 years of life. So we tend to see kids early on, unlike osteosarcoma and Ewing sarcoma. The most common sites are head and neck area, about 25%. Of the cases, GU tract follows, and then less commonly in the extremities. So we do imaging, we do biopsy. If the surgeons can take it all out from the get-go, that's okay. If not, we do chemotherapy followed by surgery and or radiation. Radiation is very effective, so we tend to use radiation a lot because, again, most of these tumors are in the head and neck area, and we prefer not to do surgeries. Overall survival is really decent. And this is my last slide. And just in case my talk was really depressing to any of you, this is my gift to you. I have 18 seconds for questions.
Any questions for Dr. Barbour? So Dr. Barbour, immune therapy for childhood cancers?
Immunotherapy, it has been really promising and working for leukemias really early and but promising for other solid tumors.
All right, thank you, Dr. Barbour.
Okay, thank you.